Hi guys, I just wanted to get the second part of the lecture done before Monday. I know you guys are really studying for the Health Alt exam, and I don't blame you. You can start this tomorrow after the test, but wanted to have it ready for you. So this PowerPoint is about the physical assessment of the newborn and how to determine their gestational age, because it is important. When you guys do go to postpartum or labor and delivery and postpartum for clinicals, this stuff will really come in handy. It'll make a lot more sense when you can get your hands on that newborn and understand what I'm talking about. Some of you may have already been in labor and delivery, but alright, well here we go. So newborn assessments. There's 3 very, very important times to complete a thorough exam. In the delivery room, immediately after that baby's born, you want to make sure that they don't need any immediate life-sustaining efforts. You'll be looking at their breathing, at their color. So basically, this kind of includes the APGARs. And then the nurse is gonna kind of look and determine if they're a preterm baby, because their needs are going to be a lot different than a term baby or even a post-term baby. If they determine that the baby's, for an example, like a 30-weeker, there's going to be a lot more. They're going to need surfactant. They're going to need caffeine. They're going to need a lot more different measures than a 38-weeker. So first time is immediately after birth. Second assessment is going to be the nursery nurse is going to do a full exam on that baby and determine a final gestational age. I know the PowerPoint says 2 hours, but if it's done within 4 to 6 hours after birth, that's okay. So the nurse is going to look the baby over from head to toe and look for any abnormalities, look for any signs and symptoms that they might be having, an age-related problem. And by age, I mean gestational age, not, 2 hours. But it's more of a related to the gestational age. And then the third thorough assessment is going to be when the nurse midwife or the nurse practitioner or even the doctor will do a complete physical exam right before they're discharged. I will tell you that I have seen nursery nurses do this second exam and catch things that the doctor didn't catch in the delivery room, the other nurse didn't catch in the delivery room, and it's not because they just skipped over it's easier to look at this baby as a whole a couple hours after they're born. So to determine the gestational age, there's a couple tools. The Dobitz tool and the Ballard tool are kind of the older ones. The new Ballard score is actually more accurate, and it really tells how the preterm babies and any baby that's over 43 weeks. There are 6 physical things that when you're doing the new Ballard score, there's 6 physical characteristics and 6 neuromuscular that are done. I do have this on our PowerPoints, but I do want you to look under the new extra material because I will show you what is there, and it makes a little bit more sense if I can get out of this. I like this one better. It's a calculator. So if you're looking at posture, which we will go through all of these, maybe the baby is scoring a 3. Square window, they're squaring a 4. I'm just putting in numbers here. Not that it really makes. So once you put in the numbers on these, it actually tallies them up and gives you a score of how old they think that baby might be versus gestational age. So look it up under the extra material and play around with it. Know your new Ballard score. And like I said, we'll go over each of the categories that are here: the posture, the square window, the arm recoil, popliteal, scarf sign, heel to ear. Those are the neuromuscular characteristics. And then the skin, the lanugo, plantar surface, breast, eye, ear, and then the genitals. We'll go over all of those. So let me just... Alright. So the first part is, well, I kind of got these all kind of combined together, but know what the new Ballard score assesses. So know each part. So resting posture is you're going to look at that baby when they are laying in their crib or on the bed, just so that they're resting on a flat surface. You're going to determine whether their legs are up or if their arms are flexed into their body. A preemie baby is going to be more stretched out, where a term baby is going to be more flexed. Skin. On a preterm baby, you can see in this middle picture here, their skin is very thin. There's very, very little fat subcutaneous tissue, and it's just very taut and very shiny. You can see everything underneath of it. In a post-term baby, they're not going to have this cheese that's in the third picture there. They have very little because it's already been absorbed into their body. Lanugo, that's that fine hair that covers the babies. They have it more, it's more prevalent in babies that are about 28 to 30 weeks. And then the farther along in gestational age they get, it actually disappears. Sole or plantar creases. This needs to be assessed within the first 12 hours, but that would be covered as long as you're doing a quick assessment at the time of birth, and then a more thorough exam within 4 to 6 hours. So in a preterm baby, they're not going to have any creases on the soles of their foot. Their skin, like every other part of their body, is going to be tight, it's going to be shiny, it's going to be thin. It starts at the toes, go towards the heel. So a baby that is term is going to have creases all the way throughout. Kind of a breakdown. Any baby that's less than 28 weeks is not going to have any creases on their foot. Babies that are 28 to 32 weeks, they're going to have some faint, thin lines. 34 to 37 weeks, they might have 1 or 2 creases. You might see 1 or 2. Kind of, if you can see in that middle picture, that major crease that goes by the top of their foot, just about a centimeter underneath their toes, that's probably what you'll see in a baby that's 34 to 37 weeks. And then anything above 37 weeks, they're basically going to have creases all the way through, like the third picture there. I like this picture here because the top of that picture, the plantar creases, there's no crease, faint red marks. That kind of starts at preemie baby and goes all the way up to term baby or post baby. Areola and breast bud tissue. When that's measured, their areola should only be between 1/2 and 1 centimeter. And the longer that the baby, or the farther along they are in gestation, the breast tissue is actually going to get larger. It increases. So a preterm baby is going to have very, very small breast tissue, breast buds, whereas a term baby or a post-term baby, it's going to have much larger. Ear form, and it's basically cartilage distribution. So in a term baby, you have this nice cartilage of their ears where you can bend their ear forward, and it'll spring back to where it was before. Preemie baby, their ears are more flat, and if you fold it over on itself, it'll actually stay in that folded position because it's basically skin and fluid. But as the term baby or the post-term baby, that ear is going to go back into the ear shape, if that makes sense. Genitalia. In the males, we're going to assess the scrotal sac, look for rugae, look for the wrinkles basically, and make sure that the testes have descended. In a term baby, when you feel their scrotal sac, as you can kind of see in this picture, the third picture on the bottom, you can tell that the testicles are descended. You can see them in the scac. But in the first picture, this preemie baby, you can definitely tell that the testes have not descended. And there's very, very little wrinkles on the premature baby in the first picture. Here's another one where it kind of goes from, on the top it says genitals male, scrotum is empty with no rugae, and then it goes up to testes are pendulous with deep rugae. So it kind of tells you what preemie is all the way up into the term or post-term. The female genitalia, basically the labia majora actually increases in size as their gestational age increases. In a preterm baby, the most dominant part of the female genitals is the clitoris. But in term babies, that's going to be covered by the labia majora. I don't think I have a picture of that. No, I don't. But look it up, and you can really tell the difference of a preterm baby versus a term or a post-term baby. Vernix, Vernix caseosa, is also called, I call it the cheese. It's that white covering that protects the baby while they're in the womb from all the fluid. Recent thoughts are that I'm going to close my door. Hold on. Recent thoughts are that the Vernix is actually good for the baby's skin. So I think some parents are really expecting to just leave it on them and let them soak it in, or as they're sitting holding the baby, they'll rub the baby and rub it into their skin. Sometimes when a baby's born and they're not as responsive as we want them to, wiping that off will stimulate them enough and make them cry and make them mad. So sometimes that's what we do to get them stimulated. Hair. Term infants have really silky strands, whereas preterm babies kind of have matted fur for hairs. Skull firmness. The skull becomes more firm as the gestational age increases. Nails. They start to appear after 20 weeks of gestation. Post-term babies may actually have really long nails. I've seen post-term babies be born and their face is all scratched up or their arm is all scratched up, or, because they are in the womb and they're scratching themselves because their nails are so long. Just double checking, make sure I covered everything I got on my notes. So those are kind of basically under the skin type, under the New Ballard score. Next one is the square window sign. This is one of those neuromuscular characteristics. If you take the baby's hand, like in the picture where they're holding it towards the wrist, the angle's actually measured. The closer the baby's hand gets to their forearm, the further along they are in gestation. So anything from like 0 to 15 degrees is 40 weeks. 30 to 40 degrees is 38 to 40 weeks. And anything over 40 degrees is considered premature. So you can kind of see this baby's probably, I don't know, maybe a 36 or a 37 weeker. Recoil is when the baby's sitting there with their arms and their legs flexed, and you straighten them out and let go. And the faster that those arms and those legs go back to the starting point or back to the flexed position, so they're all balled up, the further along their gestation is. Preterm babies, you're going to stretch them out, and they might just kind of stay there, or they might slowly go back to that starting position. But term babies have a better muscle tone, so that's why their recoil reflexes is much faster. The popliteal angle, oh, I suppose I keep forgetting that. Popliteal angle, as you can see, the thigh is flexed back up to the belly and the chest, and then the lower leg is extended up towards their face. So basically an 80-degree angle from the hip joint is common in a term baby. Scarf sign, this is when the arm is stretched across the baby's chest until they can't stretch anymore. In a term baby, the elbow will never cross midline. So this picture down here on the bottom, I would say that that baby is maybe a 36 or 37 weeker, because as you can see, that elbow is, well, it's kind of hard to tell in there. The elbow, if it's at midline or even further, then they're premature. Heel to ear extension. You're taking that baby's foot and bringing it up towards the ear. It is kind of the same thing as this popliteal angle, but it is determining how far that leg will stretch. In a preterm baby, that leg and that foot will reach right back up to the ear, and their leg will actually be straight. As you can see in this picture down here, that baby's unable to straighten their leg all the way up to their ear, so that is a term baby. Ankle dorsiflexion. If you can flex that ankle towards the skin, or towards the shin, not the skin, and then determine how much of the angle. A preterm baby will not be able to have the top of their foot touching their shin. Head leg. This is measured by, as you can see in the picture, you hold the baby's arms like in a sitting position and see how long that they can support their head. Even newborn babies should be able to support their head for, at least a couple of seconds. Preterm babies are not going to be able to support their head at all. Ventral suspension. You're kind of holding that baby on their belly and watch to see where their head and their neck are. These two pictures were taken from some good videos that actually show. So if you just Google head, leg, and ventral suspension, these videos should come up, unless I think they might be on the Blackboard site. But in a term baby, those arms are going to be flexed, those legs are going to be flexed, and their head is going to be even with their back. They're able to hold it up and not drop that head down forward towards whatever the surface is that you're holding, the floor or the table that you're holding them over. It's really kind of hard. When I'm teaching this in a face-to-face class, I usually do bring a baby doll and kind of demonstrate some of these things. So it's really kind of hard to just have the pictures here. So when you guys are going over this and you have any questions, please let me know, and so we can make sure that I've given you enough information, or maybe I can find another way to explain it for you, because I really want you guys to understand all these different things. Sorry. Other things that we look for in the babies to see how far along they are gestationally, and we went over these in the other PowerPoint, but the Moro reflex, also called the startle reflex. And this is when the baby's laying in the bassinet and you walk by and you accidentally kick your foot into the wheel, and the baby gets startled and their arms and their legs go out, they cry, and then they bring their arms back in into a flexed position again. Grasping. This is when the baby actually holds on to the fingers or whatever you put in their hand when you stroke their palm. They can actually hold on to it very tight. I have seen babies that even right after birth, they do this. They hold on to the fingers, and you can actually hold them up using their fingers. It's kind of crazy. The Babinski reflex is when you stroke the outside of the foot their toes actually fan out. Rooting, baby will start looking for, if they're a breastfed baby or bottle fed, they're going to look for that form of food. If they'll turn their face towards whatever stimulus, if you rub their cheek, and they'll start making some sucking motions and getting ready to eat. Sucking, anytime that baby's roof of their mouth is touched, the baby will actually start to suck, whether it's a pacifier or a finger or a nipple if they're breastfed. But just so you know that these are all ways to check and make sure that their neural system is intact. These videos, these links on here are all links to videos that really help explain it. So take the time and look at some of these videos. So this is the growth chart, and any of you who have children and have taken them to a well child visit, you have seen this, whether it's on the computer. I'm dating myself, but we used to actually have paper charts like this that we kept in my children's charts, and every time that I would take them in, they would take a pencil and put it on a little dot on where this goes. Now it's all done computerized, but so in order to determine if a baby's large, small, whatever, they use this growth chart. So anything below the 10th percentile, it's considered small for gestational age. Anything between the 10th and the 90th percentile is considered average or appropriate, just basically meaning that they're correct size for the gestational age that's been determined. And then anything above the 90th percentile is basically large for gestational age. All right, so that is kind of the new Ballard score in a nutshell. When looking at the baby to do a physical assessment, one of the first things that we look at is their general appearance. And this is kind of, I don't know, maybe the first assessment that we do in the delivery room. So our first thing is that we're going to say, does he look all right? Because when babies look sick, they are very, very sick. The next thing we're going to look and make sure, are they breathing without difficulty? Are there any obvious abnormalities? So generally their head is larger in comparison to the rest of their body. Their belly is going to be pronounced. It's going to be protruding. Their body's long. Their arms and legs are short. And generally they're going to be in a flexed position with their fists clenched. Sorry, I was just taking a drink. So one of the things we check is the weight of the baby. Average weight of a newborn is 7 pounds, 8 ounces. And they generally lose about 5 to 10% in the first week just because of the fluid shifts. About 3/4 of the newborn's weight is water. They're very, very full of fluid. I have had babies in the hospital that actually lost too much weight. Maybe they weren't feeding well, or maybe there was other issues, but it's very important to keep an eye on the baby's weight. Length. The best way to measure a baby, because it is way too hard to get that tape measures, and hold it up to the head of the baby or the foot of the baby. Lay them on their back and have them on a piece of paper. So mark the top of their head and then stretch one leg down and mark right below the heel. That way mom, dad, whoever has the baby there can pick the baby up, hold the baby, and you can actually measure the table from one mark to the next mark. So average length is about 20 inches, but it does range anywhere from 18 to 22 inches. Head circumference. If you look at the first picture, you can see exactly where we're supposed to measure, just above the eyebrows, using like a circular tape measure. Ranges for a head circumference are anywhere from 32 to 37 centimeters. Chest circumference, basically you measure it the exact same as the head, but you're going to measure right about the same line as their nipples. An average chest circumference is about 32 centimeters, but it does range from 30 to 35. But one interesting little fact is that the head is generally about 2 centimeters on average greater than the chest circumference. Temperature. Baby's normal skin temperature is anywhere from 96.8 to 97.8. It does take a little while to stabilize, so like I said, once baby's born, the temperature is going to be assessed like every 30 minutes until they're stable for 2 hours, and then you might only check their temperature every 8 hours. So if a baby is not kept in a warmer or not bundled, their core temperature can actually drop 0.1 of a degree, and their skin temperature can drop 0.3 degrees every minute if they're not bundled or if they're not warm. And we all know from the other side that if a baby's not warm, there are so many issues and they can just turn into cold stress, which could lead to poor feeding and low blood sugars and respiratory distress and just a whole lot more. So a big thing is to, after you're making sure that your baby's breathing, is keep them warm. But always make sure they're breathing first. The skin assessment on a baby, their color of their skin actually obviously varies depending on their ethnicity. The white American babies, I shouldn't say American, but the white babies are going to be pink or ruddy color. African Americans are going to be like a reddish brown to pale pink with maybe a yellow or red tinged skin tone. And Hispanic and Asian babies, they're going to have more like an olive or a yellow skin tone. Yeah. So now we get into a little bit more. Acrocyanosis. This is basically a bluish discoloration of that baby's hands and feet, their extremities basically, due to poor peripheral circulation. Their circulation is going to the important parts, the trunk, so like the heart and all the organs, but there's poor circulation out to the arms and the legs. I did have a baby who had acrocyanosis so bad that it literally looked as if we had already done his footprints. It was pretty, like, very, very dark blue, almost black. And all you can do is basically warm up the baby. We actually swaddled the baby and then brought him into mom and stuck him right on mom's chest, mom's belly, and then got a warm blanket for the both of them, just so we could get him warmed up and get that circulation going a little bit better. Modeling, you can see in the middle picture, that's that lacy pattern. The blood vessels are dilated under the skin just because of those weird circulation issues. Harlequin sign, as you can see in the third picture, half of that baby's body is red and the other half is normal. So basically the blood vessels are constricting on one side and it's dilating on the other. The side that's dilating is actually the red side on the left, and it's not very common, but it does happen. Know these terms, the erythema toxicum. As you can see in the first picture, it's kind of a little lesion that's around a hair follicle. Starts to show at about a day or two old. And it's kind of got this whitish yellow papule in the middle. The red portion of it can be, I don't know, 1 to 3 millimeters or in diameter. Then there's milia, which is raised white spots. Most of the time these are on the nose. You can call it baby acne. You guys have all seen it. I swear every baby that I've ever seen has milia. Skin turgor. You all know that this looks for dehydration. So when you are checking skin turgor on an infant, the belly, the forearm, or the thigh are all important places to look. Here we go with the vernix again. This is that white cheesy covering. It protects the skin in utero, moisturizes after the baby's born. That's why some parents don't want you to wipe it off. They want to rub it in. Like I said, post-term babies are going to have very, very small amount of this vernix. And if you look at this picture on the right, that is definitely a post-term baby that the vernix has is no longer there, and their skin is actually peeling, or there's desquamation going on. So take a double check on that picture there, this one right here. And yeah, it looks almost like it's blistered. Sucking blisters. Some babies have them, some babies don't. More commonly seen on their mouth like this. On the left, I don't know if you guys can see my mouse moving. But sometimes it does occur on their hands if they were sucking their fingers either in utero or after birth. Stork bites. Telangiectatic nevi. I just slaughtered that name, of course. So we'll just call them stork bites. But know the other name, the telangiectatic nevi. Basically, these are red spots either on the nape of the neck, the lower occipital bone, on their nose, and eyelids. Most commonly found on the eyelids and the nape of the neck. Congenital dermal melanocytes, also called Mongolian blue spots. These are blue spots on the baby. Generally, it's on their butt or on their backside. And it's common in the Asian, Hispanic, and African ethnicities. Some say that these go away as the baby gets older, but I have seen older people that do have these. In their early 20s, actually, was the oldest I've seen it, and she still has not grown out of it at that point. So, nevus flammeus, which is also called a port wine stain. It's a very bright red, very deep red, non-elevated area. There's just a lot of capillaries in this area. A nevus vasculosus, which is called a strawberry mark, is kind of the same thing as a port wine stain, but it's rough, it's raised, it's demarcated. It almost looks like a very dark mole, like a red mole, kind of. But just remember, the port wine stain or the nevus flammeus it's not elevated, and it's just on their skin. Whereas the nevus vasculosus or the strawberry mark, it's rough, it's raised, it's kind of a mole. Alright. Physical assessment of baby's head. Let me just double check, make sure I covered everything. Yep. There may be molding anytime that baby comes out, especially like a vertex birth. Oops. Come on. Their head actually may be what's called molded. I think we went over that last week. Basically, their cranial bones are overlapping, and that's why they have those fontanelles, so that their head can shift. As you can see in the picture down here on the left, that baby's head is very deformed, but it will go back within a little, a couple days. A cephalohematoma, I like this picture because it's got quite a bit of stuff, but a cephalohematoma, right here, is basically a pooling of the blood, or ruptured blood vessels, between the cranial bone and the outer membrane. So basically a very big bruise. Where as a caput sequoideum, it is more like an edematous, localized, soft area. These occur when they need to use either a forceps or especially a vacuum-assisted birth. These are these type of things that when I was on the other one that I was talking about jaundice, these actually put that baby at a higher level, at a higher risk for jaundice. The newborn's hair, I love this picture. I think she looks like a Cabbage Patch doll. But at term, they're going to have texture variations depending on, their ethnicity. Their scalp hair is generally high over the eyebrows. And sometimes if there's any abnormalities in the texture, or if there's any whorls, it can actually identify like any neurological, metabolic, or genetic disorders. So kind of watch their hair as well. Alright, face. One thing we really watch for when we are assessing their face, looking for the symmetry of their eyes. Are they in the same spot? Are they even? Are they set in kind of area? Sorry, I just guess I got an email. Is their nose, their ears, and their facial movement, is it all symmetrical? The sucking blister we talked about. And then always watch for facial palsy. This just basically means that one side of the face will not move when they cry, and it can be from a trauma or an issue during birth. Generally, their iris color is like a bluish gray in the white infants, and in dark brown in any of the dark-skinned babies. Their scleras might be bluish, like a bluish white. And one thing we always do is check them for perla and make sure that there's a blink reflex. Their eyelids, there's a lot of trauma. Trauma doesn't only happen to mom during the birth process, but also to the baby. Their eyelids can actually be edematous. And then I know some of you have done this already, but newborns are given erythromycin ointment in their eyes immediately after birth, just to protect them from any undiagnosed infections or STDs, so that they're not getting sick as well. Continuing on eyes, a lot of newborns actually appear cross-eyed. They have poor control of their eyes, so it's not uncommon for them to look cross-eyed. Sometimes there's black or white spots on the baby's iris. These are called brush field spots, and they are common to a trisomy 21 or a Down syndrome. As we talked about, I don't remember what it was in though. But babies don't have any tears until about 2 months old, just because those structures are not developed. So don't expect to see tears in a newborn baby. Alright, nose. We'll assess to make sure that their nose is patent, to see that baby's breathing okay and well on their own, with their mouth closed. Generally, term babies are more common nose breathers. Preterm babies might be more mouth breathers. Newborns can actually sneeze and clear out that amniotic fluid. That's how that does get cleared out. And then they can smell. Once their nasal passages are clean, they have no problem smelling. On to the mouth. So babies' lips should be pink. They should be symmetrical when the baby's crying. As I said before, touching the lips or the roof of their mouth should actually start that sucking response. There's very small amounts of saliva that the newborn has, but they can determine sweet and sour, especially if mom has had something that makes her milk taste a little bit different, or maybe a little bit sweeter, maybe a little bit sour. They can recognize that. Babies with protruding tongue can actually indicate trisomy 21. Another very, 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 and I stress very important thing to look for when you are doing that first thorough physical assessment of baby is checking their hard palate to make sure that it is intact and there's not a hole there. It's not a cleft palate. And then obviously looking at the uvula, the hangy ball thing. Alright. So Epstein pearls, as you can see on the picture on the left, small white little specks on the hard palate and the gums. It's basically just keratin containing cysts. Nothing to really be overly concerned about, but something to watch. There's also thrush. It's kind of like cottage cheese mouth. There's white patches in the mouth, and they're stuck to their mouth. And this is just an indicator of thrush. Can happen if baby's on antibiotics, or if mom's been on antibiotics, or if mom's had a yeast infection prior to or during delivery. Basically, just thrush is a yeast infection in their mouth. Another thing to look for is to see if that baby's tongue-tied. Their frenulum, as you can see in this picture, is attached to underneath the tongue. Sometimes they will clip tongue-tied babies, and sometimes they just say leave it alone. It all depends on if the baby's having issues feeding or eating. Alright, on to the ears. We talked about that their ears should be soft and they should recoil when you fold them over on themselves. Their ears should actually be even with their eyes. And as you can see in this picture, his ears are a lot lower than his eyes. You'd want them up here. I'm hoping you guys can see my mouse. But anytime that these are lower than normal, they might indicate, problem with the baby's chromosomes, or if there's a mental handicap, and sometimes even internal organ abnormalities. The neck, it's short, but it's able to hold the head. So when we are looking at the baby, we want to look for any abnormalities, such as masses or lymph nodes, or you can even see webbing on this first picture here. And especially if mom is very small or baby's very big, you want to look and check and make sure that the baby hasn't suffered a fractured clavicle. You're going to feel the crepitus in there. You're going to see the lump. Babies are, when they do their Moro-Startle reflex, it's not going to be there on this side. So if you can kind of see here, there's a little bit of a lump, and it's not symmetrical to the other side. Fractured clavicles is actually more common than you would think in labor and delivery. It's just that baby is trying to get through the birth canal, and sometimes the birth canal isn't big enough, so it squishes the baby a little too hard. I've caught fractured clavicles before, and oh, that poor baby. Their chest, generally their xiphoid process is protruding. Male and female babies actually might have engorged breast tissue or those breast buds from mom's hormones. Just make sure we're educating mom, dad, caregivers, whoever, not to squeeze or massage their breast buds because it can actually cause an abscess. Supernumerary nipples, they are more common than you would expect. They're actually located below the nipple. They don't grow. They don't contain glandular tissue, so they're not going to grow an actual breast. And it may just stay very, very small, and it might just eventually just kind of look like a white little scar. I will tell you, my daughter has one of these, and one of my very good friends was actually doing her 4 to 6 hour assessment after she was born, and Sue came in and she was just beside herself. Said, "Oh my gosh, there's something wrong with her," and I'm like, "Oh," and I was thinking the worst, and she honestly said, "Oh nope," or I honestly told her, I said, "Don't worry, it's just going to be a scar when she gets older," and she was just so worried to tell me, but as Aries grown up, it has not grown. It has stayed the same exact size as it was that she was born. So I don't think you don't think they will ever have issues with these. It's just basically it looks like a third nipple, but it'll turn into basically a scar when they're older. Baby's chest. Their breath sound should be clear. We need to monitor them closely, especially in C-section babies, because they don't get squeezed through the birth canal. Their chest is kind of a barrel shape. Their ribs are more flexible. And you can really hear their heart rate left of the sternum, lateral to the midclavicular line at the third and fourth intercostal space. I will tell you that if I haven't talked to you yet about counting babies' pulse, when you're counting it, either tap your foot or tap your finger, and that way you'll be able to watch your finger and count your finger taps, because it's really hard to count these babies' pulses because they're 160. Babies cry. Should be strong. Should be a medium pitch. Should never be a high pitch. If it's high pitched, might be something neurological that's wrong with the baby, but it can also indicate hypoglycemia. Pain is another thing that might actually, that the babies might have that high-pitched, shrill, constant. If they're born and they have a clavicular fracture, you might actually see this high-pitched, constant cry. Respirations, normal ranges are, normal ranges are 30 to 60 per minute. Might actually have periods of apnea, so count a full minute. You're going to want to watch for tachypnea, any type of retractions, if their nose is flaring, if they're having a nasal flaring, or anytime there's grunting, because this is going to be your number one priority. If you are assessing a baby and they have any of those things, the retractions, the nasal flaring, the grunting, that's going to be what you need to fix first. Yeah. Heart rates. Normal heart rate is 110 to 160 in these newborns. Kind of might be a little fluctuating or irregular, depending on what they're doing. If they're crying or they're sleeping, always listen to the heart rate for a full minute. Babies also have a murmur, if you can hear, as if it's like a swooshing sound rather than a lub-dub. It's a whoosh, whoosh, whoosh. And if you carry that with you, that is also true for adults as well. If you hear this in the newborn infant, might actually be that patent ductus arteriosus or patent foramen ovale, which both of these should be closing after birth, but if you hear that whoosh, whoosh, it may be a sign that it's not closed. Generally, we don't do blood pressures on baby. I don't even want you guys to worry about it. If they do need blood pressures, it is done in, it's there in the NICU. So really, honestly, don't worry so much about the blood pressure portion of it. Abdomen, their belly, we kind of talked about it. It's protruding. It moves with respiration. So a small hint if you're trying to count baby's respirations, put your hand on their belly, and watch how many times your hand raises, and that's their respirations. Look for distension in their belly. Bubble sounds will be present. It might take a little bit, but maybe up to 1 hour after birth, you might hear some bowel sounds. And always do some abdominal palpation, making sure that there aren't any masses or anything that we should be worried about in their bellies. Umbilical cord, I know we went over this in the last PowerPoint. 2 arteries, 1 vein. Always, always, always look at that cord once it's cut. And like I said before, it's dry and black within a day or two, and then it'll fall off within 2 weeks. Always make sure to educate your parents on the fact that this does not hurt baby. It's like your fingernails or your hair. It's basically dead material. Alright, so in the genitals for female, there might be some almost like a white cheesy stuff. This is called smegma. It's present between the labia. Never ever ever wash this off with like a washcloth or scrub it off, because it is on there very thick, and if you scrub it off hard enough, you could actually damage their good tissue. Pseudomenstruation, we talked about that in the other lecture. Might actually happen during the first week. It basically looks like the baby's having her first period. And then we want to make sure that we're looking for the labia minora, the labia majora, and the clitoris, and making sure that they're all there and all appropriate for their gestational age. In the male, we want to inspect their penis for the meatus. And the meatus can be in different places. Like a hypospadias, that meatus is located underneath the penis, where in an epispadias, it's on the top of the penis. Phimosis is another vocabulary word. Basically what it means is that foreskin isn't able to be retracted. Cryptorchidism, basically the testes haven't descended. I know when we were talking about the new Ballard score, we talked a little bit about that. But they aren't descended, and they aren't in the scrotal sac. Hydrocele, these babies, instead of their testes descending, there's a collection of fluid in there, which it can be absorbed. Might take a bit, but yeah, I think that's it for that slide. So physical assessment of their anus or their rectum. Always look at their backside and make sure that rectal sphincter is in the right place. And we want them to pass their first meconium stool within 24 hours. If they haven't passed their stool within 24 hours, then we need to really start being worried that rectum isn't patent and maybe there is no opening. If there isn't a stool pass within the 24 hours, there might be atresia of the GI tract, or there might be an ileus caused by the meconium. There's just so many scary things that it could be, to make sure that this baby is pooping within the first 24 hours. Arms and hands. There's a few different vocabulary here. Polydactyly. I like to get the most dramatic pictures. But if you look here, this is polydactyly. There's extra digits on their hands and their feet. This baby on the left has, 5, 6, 7, 8. Yep, 8 on both sides. These are actually very well formed for being extra digits. I've seen it where they've had just like a little growth off, like maybe their thumb that has a fingernail on it. They're kind of crazy. Syndactyly, where these digits, their hands or their fingers or their toes, are webbed together. And then if you look at their hand, this single crease across their hand might actually indicate Down syndrome as well. Brachial palsy, this is also caused by trauma during the birth. Might actually have paralysis to their arm. And then this Erb's palsy is basically damage to the upper arm, neurological nerve damage. Legs and feet. Their legs should be equal in length. Their skin fold should be symmetrical. Always look at their feet for clubfoot or the Talipes deformity. It could be just the way they're positioned, or it could very well possibly be true clubfoot. The Barlow and the Ortolani maneuver, you guys have all seen physicians do that. These are those two pictures down in the corner, just to make sure that these hips are not dislocated, and then make sure they're in the right place. Looking at doing the physical assessment of the baby's back, the back should be straight because curves don't actually start to show up until that baby can sit. And then there's a thing called the nevus pilosus, also called the hairy nerve, which is present at the base of the spine, and this is actually caused by spina bifida. These babies might actually have a pilonidal dimple at the base of their spine, whereas you can see in this picture, it almost looks like there's a hole going in right just above their little butt crack. And that's a major sign of spina bifida. You can actually have those little pilonidal dimples without having spina bifida, but as you're doing your assessment, and if you find that on a baby, you need to report that to the provider and get them an x-ray as soon as possible, just to make sure that there's not any issues with them possibly having the spina bifida. I've seen babies that have a very pronounced dimple here, but they did not have spina bifida. All right, pain scale for these babies, because you can't just say what's your pain rating. We actually do like a nonverbal scale on these babies. We look at their facial expression. If it's relaxed or if it's contracted, we give them 0 for relaxed, 1 point for contracted. We also look at cry, breathing, arms, legs, alertness. So each thing can get up to 0 or 1 point, except for the cry can actually get up to 2 points. So yeah, they just determine each of the topics there. There's also the FLAC scale, where you're looking at their face, their legs, their activity, their cry, and their consolability. As you can see on this, if they are relaxed, their legs are in a normal position, they're laying quietly, they're not crying, and they just look content, they're going to score a 0. But if they have any of these they're arched or they're rigid or they're jerking or they've looked tense or if they're squirming, if they're difficult to console or comfort, they're going to get different scores, and it's going to add up to 10, or quite possibly up to 10. And then you can use this to medicate appropriately. This will just kind of go through a little bit. The Brazelton score is not used very often anymore. It's just kind of getting outdated. But I want to go through some of the verbal or the vocabulary with this. So habituation, I think that was in the last slide, where these babies are able to shut out a stimulus. This is the one I joke and say I wish I still had that today so I could shut out my kids when they say mom 647,822 times in a day. Um, you can look and see in this Brazelton assessment, how do they respond to the stimuli? Are they oriented to an inanimate or animate visual and auditory stimulus? Their motor activities assessed. Basically, they're looking at the baby and seeing how their muscle tone is. Um, how often are they in an awake state? How often do they change states? It just kind of depends on what their temperament is. That's kind of what that's looking for. Trying to determine if they're able to adapt to a new environment. This scale kind of gives an idea, a better understanding of what babies are able to do. So it is used, but it's not used as much. Then we got a couple more here. The self-quieting activity. How able is that baby to self-soothe themselves? How quickly, how often, and how effective are they? Their cuddliness and their social activity is also going to be assessed. Just to see how they respond to being cuddled, being held. Sometimes babies, especially NAS babies, they're not able to handle the stimulus of being cuddled, of being held all the time. The NAS babies have to be in a dark room with very, very little stimulus, and you usually bounce and pat their butt. You cannot do any of that. So they're kind of looking at how does this baby deal with being cuddled. So I think that is everything. As I hope you guys do well on your health alt test tomorrow. That's why I kind of want to get this out, because I wasn't sure if anybody was going to start studying and looking at this stuff before you guys were finished with that. But as always, please, please, please get a hold of me if you have any questions. You can email me. You can text me. I think I missed a couple emails before the test, but I knew that the questions weren't on the test, but I apologize for not getting back to you on them. But if there is anything, actually I think probably the best if you have a question is to text me if you want, and then if it's a long drawn out thing, just tell me, hey, check your email. I got a new phone and my phone isn't telling me when I have new issues or new things, so just kind of make sure that you get a hold of me if you're having any issues understanding this. Other than that, I think this is pretty much it with both the lectures, and I will do the exam review as well to kind of condense some of this, because there is a lot of stuff here. But get a hold of me if you need anything. All right, thanks, guys. Have a good night.